So for pictures, I always like to have my patient's eye level, and the patient is the one that is supposed to rotate, not you around the chair. The recommendation is to pick an area where you're always going to have the same lighting. And even if you want to mark the actual floor, to have the patient rotate like in the same angles, because you want consistent pictures. That's the most important, consistency. So same lighting, same spot, same angles. If your eye is still not well trained to get those perfect angles, a good way of doing it, there's mats that the companies will provide you with the different angles. But if not, just put a little piece of tape on your scotch tape on your floor so the patients know exactly where to stop. So what I tell my patients is nice and straight, right? Looking at me.
Yeah.
And you can always zoom in your picture. So I'll show you my picture. I'll show you my phone right now and show you the picture that I'm taking. So give me an angry look. Perfect. Go ahead and raise your eyebrows for me, nice and high. Perfect. Give me a big, big smile. Perfect. Rotation or the inclination that we talked about whenever we're going to do under eye filler. And even if the patient is not planning on doing any filler or any under eye filler, I take every single picture the first time that I meet them, because then in the future they might want to like explore fillers, and then you have the perfect picture to compare. Like you go to the first one that you took ever. So now you're going to turn just a little bit, your whole body. Turn. There, perfect right there. Nice and relaxed. Your head with your body. There you go. So these 3/4 angle picture, let me see if I can show you. The 3/4 angle picture, the angle that you want is to be able to see the other cheek. So you have to be able to see the contour of the opposite cheek that you're taking the picture. If not, if you take the picture, let's say, let me take one. If you take it with the patient turning too much, you see how you cannot see the cheek right there? That you will never be able to compare temples, you will never be able to compare cheeks properly. So it's really, really important. And when you take that 3/4 profile, you have to be able to see the other cheek, the contour of the other cheek. So you need to see the nose and the contour of the other cheek. Okay. And then I take also a lateral profile. So you're going to turn all the way that way. Lower your chin. Very good. So we naturally try to kind of like lift the chin, right? Because that looks better. So make sure whenever you're taking those pictures, especially if you're planning on doing jawline, chin, cavella, anything that you really need to compare that on that submental area, that the patient is looking nice and straight. Okay. And I have Dr. Sewell sitting down because I'm so short, right? But whenever you have a male patient, just have him sitting down so you can take the picture nice and eye level, okay? With females, I normally just like step in my tippy toes into it. But whenever they're tall, just have them sit down and have it at the eye level. So you're supposed to have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 pictures. Frontal view, relax, angry look, raising brows, smiling nice and big. You can even take a smiling at 3/4 because that's nice to compare the crow's feet if you're doing Botox or hair modulators. And always take your 3/4 profile and then your lateral profile. And like I said, even if a patient is not planning on doing filler and we're just getting to know each other, I always take a full set of pictures in their first appointment just so we can have a good baseline to compare with. Sometimes it's super fun, like whenever you have seen the patient for years and years, just for fun, I like to compare the first picture that we ever took whenever we met them, and then the one that we took that day, and it's like night and day. It's awesome. Yeah. So same lighting, same spot, do your tapes on your floor so you can have like the same angles. Just consistency is what works best. I actually don't like the pictures in the chair. I feel like they don't look as professional. If you have, even behind your door, you can put like a little screen that you can pull down, either black or blue or whatever, and it just makes the pictures look so much more professional. So we're going to continue with the male injection, right? And now we're going to do a little consult, and we're going to do a little bit of filler on his cheeks. So I know we did a consult last time, but we're gonna review the consult, right? Because now it's gonna be a little bit more expensive. Because we're gonna do fillers. So we know that no allergies to any medications, right?
No,
Any prescriptions that you take at home.
no prescriptions.
Okay. Any dental procedures that you have done in the last 2 weeks, even cleaning,
No.
and you don't have anything planned in the next 2 weeks dental.
No.
Okay. Any vaccines in the last 2 weeks,
No.
and you don't have anything planned for the next 2. Okay, very good. So those are really the questions that I ask when I do filler. Do you take any, you said no medications, but do you take any fish oil and vitamin E? Have you taken any ibuprofen in the last couple of days?
No.
Okay, very good. So, and if the patient took any of that, it's still not a contraindication. Just let them know that they might bleed and they might bruise a little bit easier than if you didn't take it. What else? Alcohol?
Don't drink.
No. I think that's it. Those are the big ones. Any aspirin, ibuprofen, alcohol. And that is, again, not a contraindication. You don't want to treat somebody completely hangover because they normally bruise. I've done it before. Patients sometimes come in and they're like, oh, I drank a little bit yesterday. I'm like, okay, we can treat you, but you're probably going to bruise. And yes, they end up bruising. So alcohol is a big one. Fish oil, vitamin E, ginkgo biloba, ginseng, garlic. They say that anything that starts with a G, it's kind of like a little bit of a blood thinner. Do you have any questions before we start, before I explain everything to you?
I think my question would be like, will I look natural? Will I look overdone? Yeah, will people be able to tell?
Yes. So, and that's one of the big questions, really, for males, especially for females as well, for males especially. The product that we're going to do, the fillers, right? The product that we're going to do today, it's an HA filler. So it's a hyaluronic acid filler. It's a complete clear gel, right? That will get completely absorbed into your body after the indicated time. Tonight we're going to use Restylane Lift, which is indicated for cheeks, right? And that one is indicated for 12 to 18 months. So during the next 12 to 18 months, that clear, completely clear gel is going to start breaking apart very slowly, very gradually, right? And it doesn't leave any residues behind. So it's very similar to your HA, to your natural HA. We all have hyaluronic acid in our face, in our hair, in our skin. So it's nothing foreign for the body, which makes it safer, right? It does come mixed with a little bit of lidocaine, okay? So you're still gonna feel a little bit of the prick of the needle, and then you're gonna feel a little bit numb, okay? It's super simple. You're gonna be able to see it right away, which is really nice. So what I'm gonna do one cheek first, and then let you compare, okay? So to the other cheek that doesn't have any product. The fillers, or majority of the fillers, they come prepackaged in 1 ml syringes. So that 1 ml syringe, if you take the full product out of the syringe and you put it into a teaspoon, it's only a fifth of a teaspoon. It's a tiny, tiny amount that we're gonna do. So it's a fifth of a teaspoon, and it's kind of like spread around, right? With males, remember what we talked last time, right? We are supposed to volumize a little bit more the medial aspect of the face than the lateral aspect. But that doesn't mean that we're not going to do a little bit on the lateral as well. So we will do a little bit on the lateral, but it's going to be more medial. And we all have asymmetries, right, in our faces. You're not the exception. I feel these cheeks a little bit kind of like more volume loss than this one. You see how this one looks fuller right here, and this one looks a little bit more depleted. So I may play with the amounts that I'm going to do. I may do 0.8 and 1.2 on the other one, okay, just to play with those asymmetries. We all have asymmetries. That's completely not normal, okay, and natural. Sometimes it's how we sleep. Sometimes it's just, or we all have asymmetries. It's just natural. So we can always play with those asymmetries whenever we do that filler. You're gonna be able to see it right away. If, let's say, right, because this is your first time, let's say for some reason you didn't like it, these products we can dissolve. So you're not stuck with a product. I feel like that is like a big one for patients to hear. Whenever they hear that, they're like, okay, let's try it. And I know we know they're gonna love it, but I feel like that helps the patient to feel more relaxed about their treatment and be more open to try it, because nobody wants to be stuck with something for a year and a half to 2 years if they don't like it. So these products we can dissolve. They're an HA product. They're the safest in the market because they are dissolvable, right? There's different products in the market like Radies or Bellafield that are not dissolvable. So HA filler powder is going to be your safest bet.
Gotcha.
Okay, it's super simple. Any other questions?
Yeah, I have a question, like,
Uh-huh.
if I like the way the filler is,
Mhm.
do I move to a permanent one later?
No, so the fillers, we're gonna have to be kind of like keeping up with them, right? If we do the filler today and you love how they look, that doesn't mean that you're not gonna do anything until the next year and a half, okay? Because remember, those products are gonna be breaking kind of like slowly and gradually. That's why it's so good that you're doing your Botox, because that will give me an opportunity to see you every 3 or 4 months, right? And let's say for the next 6 months or 9 months, you're not gonna need any filler, right? Because that's gonna be holding you. But let's say 9 months from now, or in a year from now, we start seeing that volume kind of like starting to go away. We can replenish it with just one and do half and half. And at that point, you're just maintaining your volume. So I tell my patients, when you do their treatment for the first time, right, you don't need a lot of filler, but let's say like my patient population, it's 50s, 60s, right? So whenever they come in and we do the consult, I'm like, well, you're gonna need 4 syringes up here, 2 up there. So they end up with like maybe a list of 10 syringes for their total treatment. And I always tell my patients, listen, you haven't done anything, right? So we're kind of like, it's like when you go to the gas station with your tank completely empty, right? It's gonna be a little bit more expensive to fill it up. But after you do that, after you are where you want to be, don't let it go all the way to E, right? Don't let all the filler kind of like deplete completely. So just come back and then do little touch-ups here and there. So what I tell my patients is, let's say they come in, we do a consult of 10 syringes, they come in 2 or 3 appointments, we finish their treatment, they look amazing, right? That doesn't give them the opportunity to go and never see me again for 2 years, right? Still come for your blood talks, right? So I can keep an eye on you. And then maybe every year we'll do maybe 1 syringe here, 1 syringe there, 1 or 2 syringes per year. That's normally what I tell them that they're gonna need for me.
The other question I was just trying to think, like, what would most people ask is like, what happens after I get the filler? Like, is there any contraindications or anything that I have to do?
So yes, so the aftercare, so no exercise for the first 24 hours, especially if you bruise.
Okay.
So if you bruise and you go out of here and you go straight to the gym and you increase your blood pressure, same as when we did the Botox, right? You're gonna make that bruise bigger and you're gonna create a little bit more swelling, right? You will have a little bit of swelling. You're probably gonna have a little bit of bruising. With cheeks, we don't see a lot of bruising going on, but definitely a little bit of swelling. The product is gonna feel a little bit bumpy for the first couple of days. For the first 10 days to 2 weeks, okay? It's gonna feel a little bit bumpy, super normal, okay? Don't mold it, don't touch it, don't massage it, don't press on it, just let it settle, okay? The body creates a little bit of swelling surrounding that little product that we just placed right under the skin. And really what you're feeling is just a little bit of that swelling that the body creates. And the product is gonna integrate into the tissue as well. So it's gonna go from a little bolus, right, that we place into tiny little boluses floating in the same area. So that's why you're not gonna feel it anymore later on. So, but for the first 10 days to 2 weeks, you might feel a little bit bumpy. If you're washing your face or you're putting your sunscreen on, you're gonna feel like bump, 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 where with the product that's completely normal, okay? It's not gonna stay like that, just leave it time, okay? And then, so no exercise for the first 24, no alcohol for the first 24, ibuprofen or aspirin or fish oil or any of the blood thinners, right? Or no, any of that for the first 24 hours. Try to sleep on your back. That's regardless if filler or no filler. I always tell my patients, start to learn to sleep on your back because that's going to make a big difference on how your face ages over time. No vaccines, no dental for 2 weeks. That's it. Super simple. So I don't know if you see how kind of like his temples are bulging a little bit. So I have some male patients that request neuromodulators in the temples, just like the masseter, right? And I think it's a good kind of like complement to the masseters whenever patients do masseters. I don't treat temples on everybody, especially not on females, unless they are really kind of like complaining of pain there. But males, sometimes it's a good complement to the temples, completely off label. Okay, this is off label. So if it's Botox, I do 16 units, so 4 dots of 4 units. And if it's this sport, I do 40 units, so 4 dots of 10 units. So, and how you would mark temporal crest, right? and then lateral canthus. So that's kind of like your temple area. And we know it extends kind of like far back over here, but we're gonna treat just right here, okay? Maybe I should try this.
I have a huge, I have like a huge eyebrows.
So remember that the temple, right, it has 10 layers of tissue. And the muscle is kind of like on the deeper level, okay? It's the bone, then the muscle, and then 9 other layers. So you have to go deep on those injections. You can use your insulin syringe if you want to, but it has to be at least the 8 millimeters, okay, length, if not the 1/2 inch, okay? So you can reach really the muscle, okay? And again.
You see, okay?
So all the way in, okay, with the needle. And this one, if you see, I'm kind of like on the hairline, that's perfectly fine. Remember that the temporal muscle is kind of like elongated all the way over here. Okay. Super simple.
Yeah.
So good. So if it was Botox, again, 16 units, 4 units on each dot. If it was Dysport, it's 40 units, 10 units on each dot. That's what I do. And then masseters off-label as well. I normally do 20 to 24 units of Botox or 40 to 50 of Dysport. And patients are so happy whenever the Botox kicks in right there, especially if they're like having pain with it. And of course, it will be kind of like left protruding. So let me clean the cheeks, right? And let's start marking. For the cheeks, I always like to do the Hinder's lines, even after so long of doing like fillers or injectables. I feel like it allows me to kind of like visualize better where I want the filler. And we can talk about his chin as well. We're not going to inject because we can't, right, with the beard. But remember, when we treat chins on males, or parameters, right, are the oral commissures. Let's see, good. So we can make their chins a little bit broader. Sometimes even we inject in a 2 little pattern, 2 injection points instead of just 1, because we have the luxury to make this chin broader because that looks better in males. With females, remember, you always stay kind of like medial, right, into the midline, and then you treat very kind of like centered in the medial area for females because you want the little kind of like more peaky look, more feminine look. When with males, you can even try to replicate the little chin, the cleft chin, that it's kind of like the Disney princesses. That they always have like a cleft chin.
Oh, yeah.
So for the Hinder's lines, you're gonna do ala of the nose, mid tragus, and then lateral canthus to oral commissure. And that will leave you 4 zones. I'm gonna write it down really quick. So B1, B2, B3, and B4. Not everybody needs B4, right? B4 is gonna be kind of like under the zygoma, more for your more mature patients with thinner faces, kind of like sunken periauricular area. So that sometimes is a great area to fill, but we're gonna concentrate. He has good volume on B2, but he's missing B1 and B3. So again, males carry their volume more medially, kind of like on the apple of the cheek, right, or B3. So we're gonna do a little bit of injections right there. And then something that I normally mark when I do my cheeks is if they are starting to show some of the ligaments, right? Kind of like the retaining cutaneous ligament that you can see a little bit kind of like showing right there. And then the soup right here. So I normally mark those just to kind of like have them in mind when I'm injecting. You can see the retaining ligament right there trying to show. And then I can see the soup right here starting to show as well. So I always mark those. And the soup, you know, it's that deep fat pad that we have right there. Mother Nature, don't ask me why, but the superficial fat pads shrink faster than the deep ones. So one of the first ones that we start seeing showing is that soup orbicularis oculi fat pad. So I always mark those. For confidence, to well from sure. His fat pads, his soups are not super prominent. But whenever you have patients that the soup is like nice and prominent, I normally let the patient know, even before we touch him, I show them the mirror, right? And I explain what everything is. And I explain to them, the soup is not going away, right? That one is not moving, not with surgery, that one is staying. What we are trying to do is kind of like add a tiny little bit of volume surrounding it so we can mask it again, like, or hide it like it used to be whenever we were younger, right? Because for some patients, it's so prominent that even after you put the filler, you're still going to be able to see it. So if you don't mention it before, they're going to think that it's like a bump that you gave them with the filler. So that's very important. Before starting to treat the patient, just mark everything and let him see it before you even touch him. That I feel is so important for the patient to be happy. And I normally clean with 2 different antiseptics. I use alcohol first. I use chlorhexidine in the office. And this area is nice and clean, so I just dab a little bit over it. And have your patients close their eyes when you're doing the chlorhexidine because it's very irritating for the eye. So Restylane Lift, okay? So Restylane Lift comes with a little label. It has just one label. And it's in the syringe, so take it off. And then the Restylane syringes, it's actually 3 parts. So you have to hold this part, the bottom portion, before removing the top. If not, then you can bring this little portion with you. So just hold it and then remove the little cap. Hold the little white part, the bottom part, and then remove the top. Because if not, then you're gonna bring up this one too. And then you just warm up the syringe for the needle to the syringe. And that's it. Ready to go. Okay, 1 ml of product. It always comes with a little bit of a pre-fill. And again, this is his better looking cheek. Okay, so I don't think we're gonna do the full syringe. I want to do a tiny little bit medially and then a tiny little bit right here. So we might use a cannula for this lateral area, okay? But definitely needle in this area right here.
Okay.
Very Austin, okay? You're touching bone. And then you're gonna aspirate. Remember, a good aspiration is 6 to 8 seconds. Like that. And then we're gonna push nice and slow. Should take 6 to 8 seconds for a point work. Nice and slow. And always kind of like assessing the patient, assessing the skin, everything, right? With that, as you are pushing. If the patient complains of pain, that's not normal, so you have to stop right away. It shouldn't hurt, right? How was it?
Didn't do it at all.
Good.
I guess felt like a little pop or something. Was it-
Yeah, and as we move laterally, you're gonna be able to hear even more that those little pops. I call it a crunch. So that's super normal, okay? It's super normal. I know it's not fun for you as a patient, but it's very, very important. Yeah.
It almost felt like that was the product going into me.
Yeah.
Because
Yeah.
it didn't feel like it was the periosteum.
Yeah. Yeah. Sometimes you can even hear the product like Like
Yeah.
going in as the more we can we get closer to your ear, the more you're gonna be able to feel. Mhm. Beautiful. Okay. And then you have time right here because this is where she doesn't need it that much. That's great. Lift is a great product because it really lifts. I think they gave them the perfect name. Imagine almost like a little Hershey's kiss kind of like shape under the tissue, and it just kind of like stays there really, really nicely. So when you have patients with like good quality skin, like thick skin, lift is amazing. So we're gonna be moving laterally. And you see how much better it looks already. So the retaining ligament that we were seeing right here, it's kind of like getting softer, and the soup as well. So you don't see it as much. So that's what we're gonna be looking for. And I'm doing tiny amounts. The first injection that I did was a little bit over 1. This one was a 0.05. And I don't know if you see it, but every time I inject, I'm kind of like pulling the skin up. I feel that gives so much lift. So it's kind of like when you pull kind of like a fabric and you do a little nail in it, and it kind of like stays in there. So I always do that. I always do. We change the needle.
So they look pretty good.
Looks good. That looks really good. Okay, I'm gonna change the needle. I'm gonna do a tiny little bit more right here. Just where, because when you smile, I don't wanna give you a lot of fullness right here, because when you smile, I can see that natural fullness that you have right there. So I'm gonna do maybe one here, and that's it. Mhm.
They don't hurt at all. You can just hear like the.
A little crunch.
Yeah.
Mhm. Give me a big smile. Big smile. Big smile. So I did a 0.6. We were planning for 0.8, but I think 0.6 looks really good. So at this point, when I've done one side, right, I always have the patient look at it, okay, with a handheld mirror, because I feel that's the best way that they can compare. Even if you did the 1-in-1 and you're loving the result of one side, I feel if you do both sides and then show the patient is, it's probably not going to be able to compare the difference.
Yeah.
You see that? And it's so subtle at the same time,
Yeah.
but it's so awesome. And right now you can't see the lift that you have right here because of the beard. But whenever female patients are doing it and you're kind of like, and we didn't give you any volume right here because you're a male, right? But whenever we do females that we do all these volume right here, the yawning almost disappears. It's
Wow.
like amazing.
I can see on the mirror is just like this area is so much better.
Mm-hmm.
Then so here's this area, and then you look at the other cheek.
Compare just looking at nice and straight. Look at the line, the ligament right there, kind of like pulling down right there. Look at the soup, how you can see it and how you cannot see it over here. And look at kind of like the lift that is giving to the whole face.
Wow.
It's
You
awesome.
can definitely see with 10-inch lighting.
Yeah, it's awesome. So let's do the other side.
This one? Sorry.
And everybody has a different way of aspirating, right? My hands are small, so I have to kind of like let go and change my position. As long as you kind of like get used to, regardless of what way you aspirate, just make sure that you're nice and steady and the needle is not moving at all.
Good.
I know there's injectors that like to start laterally and then come medially. I just do it this way. I don't add everything medially first. So I add just a tiny little bit medially, go all the way lateral, and then most of the time come back and do a tiny little drop medially. That's just what I do. I love Dr. DeMaio, but I feel like not every patient is gonna be, you cannot treat everybody the same. It's an art. So you have to do it slowly and kind of like looking and reassessing. And I'm always kind of like comparing to this side when I'm injecting. And this is the area where he has a little bit more volume, so we're going to do a tiny amount right there. But still give a little bit of support. That's good. Okay, so now let's go this way. And every time I feel like the needle is getting dull, I just change it. If you have like extra needles left, always save them because they always come so handy. Thank you. Can you hear the product?
Mhm.
You're probably gonna get a little bruise in there.
Oh, no worries. I can totally hear it in the last one. It sounded like a flow.
Like,
Yeah,
I could,
exactly.
I could feel it in this room.
But none of them really hurt. I don't know.
No, it's really not bad.
I don't
I
think,
feel the thing that the patients complain the most about is the little crunch. That little crunch
Just
when the needle
unnerving,
goes in.
just-
Mhm, yeah. And if you have a little bit of blood like that, that's okay. Okay, he's probably gonna get a little bruise. I feel the best way to kind of like diminish that bruise from really getting big is taking a minute out of your treatment and put pressure right away. So just hold it, put pressure, because that is gonna allow that coagulation time, right, to stop the bleeding inside. If you let it bleed and bleed and bleed and you go on to the next injection point, you're just gonna make that area bigger. So just take a minute from your treatment and do pressure. I feel sometimes I tell the patients, oh, you're gonna bruise, and then they come back and they're like, oh, I never did. Hopefully that will be the case. And always reassessing, right? Assessing your skin, the color. He's not getting a lot of swelling, so I don't think he's, there's patients that you just touch him and they swell, and some others don't. I don't think you're gonna be one of the big swellers. If you have a patient that swells a lot, normally they can take Allegra, phenoxyphenidine, over the counter, and that tends to help with a little bit with swelling. And bromelain as well. Bromelain is the enzyme of the pineapple. They sell them as a vitamin. And of course, arnica, right? Arnica for the bruising. I think you've never seen that. It looks good. I like it. I'm gonna do a little bit more right here, just a tiny drop. Right here. And then maybe come back and do a tiny drop extra right here. Go ahead and give me a big smile. I may do a tiny drop or not. Let me do this too.
Okay.
So I'm gonna change the needle again because we need a little bit. Okay. And what I tell my patients with cheeks is you're not going to look different. You're just going to look kind of like refreshed. It's going to be so hard for anyone to put the finger on what we just did. You just look refreshed. It looks awesome. The higher you go or the closer to the ear you go, remember that zygoma is it's going from thick to really, really thin. So I don't know if you saw how I kind of like looked for the bone and just kept it in between my fingers to guide my needle, because the injections have to be peri-ostium. They have to be touching bone. I like that. Go ahead and give me a big smile. Okay, perfect. I think that's perfect. So we did a full 0.1 on your left cheek and then a 0.6 on your right. And I think that looks great. It gave you support like immediately. We could, I wouldn't do it in the same day. I normally do my treatments, let those first syringe or 2 syringes settle, and then have you come back. But you could do maybe a tiny little bit of contour, Restylane contour, just to give you a little bit of support right here. And because contour is a little bit softer than lift. So the one that we just did is perfect for what we did, right? To give you that little lift and that kind of like projection right here. But if we did a tiny little bit of contour with cannula, right? Maybe half and half, that will be nice too, because it's going to give you a lot of support on your eye, on the under eye. But I think it looks awesome right now.
And you wait till the next session
Yeah.
to do that? Because of the
Especially,
swelling?
yeah, because of the swelling, because of the bruising, we don't want to overdo it. So I tell my patients, this is a marathon, not a sprint, right? Let's go do it slowly. And that way patients end up looking super good with the least amount of product. Because right now it may look like you need the full syringe, but you might be good with less than that. So I think it looks beautiful.
Yeah, wow.
It looks so good. So good. It's giving support on the under eye. That ligament that we were seeing right here, it's like gone. It looks really good.
Yeah.
Yeah.
It's
Yeah. And you see, you don't look different. It looks awesome. And I normally, after the treatment, right, I massage with a little bit of bacitracin, which I know a little bit. So I massage with a little bit of bacitracin, and then I let my patient know, don't touch it, don't put any, well, not makeup for you, but no sunscreen, don't wash your face, don't touch your face, okay? Definitely for the first 4 to 6 hours, okay? Especially if we use cannula. If we use a cannula, remember that that little cannula entry point is going to be a little bit bigger, okay, than just the needle. So it's very important not to touch the skin, not to put any sunscreen or nothing over the little cannula entry point or the needle entry points. So we don't introduce any bacteria, but particularly with cannula. If we were doing cannula, I normally use the 25 gauge cannula. And what I do, I create a little entry point. And it depends really on the plan, right? What treatment plan are we having for the patient? If it's a female and you want to reach all the way over here, if it's a female and you want to reach all the way lateral, well, you kind of like gauging on the length of your cannula, right? You're going to do your entry point around here and then go all the way with the cannula, right? And create that little volume right there. When you're treating kind of like the lateral aspect over that lateral aspect of that zygoma where it's like really, really tiny, I feel the cannula is the best way of doing it. It's just easier for you, for the patient, for everybody. Once it starts getting super thin, sometimes it's so hard to kind of like find the bone and you have to be kind of like moving and trying to find it. So the cannula is so much easier when you do that area. And remember, you're going to feel those little bumps, okay? That's super normal. The area where you gave me the little drop of blood, where you can develop a little bruise. So with cheeks, we don't see the color of the bruise as often as if we were doing lips or chins or anything like that, because the bruise is deep, right? We were placing the product deep, so the bruise is deep as well. So if you happen to create a little bruise right there, you're probably not going to see the color of the bruise. You're just going to feel one of those bumps that you're going to be feeling. It's going to feel a little bit extra tender. Okay, so that is the bruise that you have right there, but it's deep, so you don't see the color of it. So if you feel that little bump that it's a little bit extra tender, that's probably a bruise. Tenderness is completely normal, okay? I remember when I did my first treatment of cheeks, I did took a little bit of Tylenol that night. So tenderness is normal, a little bit of swelling is normal, a little bit of bruising is normal, okay? That's super normal anytime we do filler. What is never normal is pain. If something hurts, that's not normal, okay? So you have to let us know right away. If something is excessively swollen or excessively bruised, that's not normal either, okay? So that's something that you need to report right away as well. If you're developing a bruise where we didn't inject, let's say we did the cheeks, but you're bruising on your nose, your chin, your temple, that's not normal, so you have to let us know. If we were doing chin, right, on top of the instructions that I just gave you, I normally let my patients know that if they notice any changes with their tongue, to let us know as well. Because remember that the sublingual artery runs kind of like close to where we do the injections with the chin. So any changes in the tongue, any numbness, any blanching, any tingling, pain, anything like that, that's something that they need to report right away. Okay. But with cheeks, you're good. Just a little bit of swelling, little bit of bruising, little bit of tenderness.
Awesome.
That's
Yeah.
what we expect. It looks really good.
Well, thank you.
I like
It
it.
wasn't
I like
painful at all. Like it was
Good,
surprising.
good. I'm telling you, the cheeks is one of the easy ones. I know a lot of patients are afraid of it. I feel that what they are most afraid of is the results. But as you can see, it's awesome.
Yeah.
It looks really, really good. Do we have any questions?
Yeah, for males, do you match more along the line you drew from nasal ali to the tragus versus women more superior to give them a higher cheekbone?
You know what? I do the same lines, but with females, sometimes I do an extra third line, kind of like dividing that little triangle. So what I do, I still do the hinders, right? So mid tragus, ala. So mid tragus, ala of the nose, right? And then lateral canthus to oral commissure. And sometimes for females, just to get kind of like a better perspective or where I want to do it, I do an extra line kind of like dividing these ones, because this is really where you want the volume for the females. And it's not just for females. So if you have a more mature patient where you're going to need to volumize everything, right? You're going to start doing the injections just like I did them right now. Because if you inject this way, you're going to volumize this way. You're going to make that cheek a little bit bigger or wider. If you angle your needle this way, right? Like when we do the females, you're going to be giving that lift. You're going to be giving the volume as well, but a little bit of a lift. So it really it has to do with where or the angle of your injection. So if you go this way, you're going to volumize. If you go this way, you're going to volumize with a lift.
That was one of the hardest concepts for me to grasp, like when I first started injecting.
Yeah.
Like you said, to go at that angle. It
Yes.
gives a lift.
Yeah, it gives a beautiful lift,
Mhm.
and it gives a little bit of the volume as well, but it gives
Mhm.
the lift. And if you have a very depleted patient, right, you're going to start with this one, right? Because you need to kind of like volumize a little bit. But when you are working more on those contours that you're trying to create, you're going to go a little bit more in.
Does the angle of the needle or the syringe make sense too
Yeah.
for them? Just
So instead of going this way, right, you go this way to create that lift instead of going this way. If you go this way, you're going to create volume, right? And then the beautiful OG curve. But this way, you kind of like lift and volumize at the same time.
almost like a lifting movement.
Yeah.
With your,
And on top of the pulling that I normally do, because I think that works just beautiful. Whenever you pull, I feel like you pull the little bolus, you place the little bolus right there, and it kind of like just holds the skin from going back. It just gives you the little lift very nicely.
And they were saying, would that give them the OG curve?
Yes, that's what
That's
we're
it.
trying to recreate.
Okay.
Yeah, definitely. With all the injections that we do on the Sewell, that's what we're trying to create the OG.
I had a question just regarding like males. How do you know? Because I know males have more volume medially than laterally, right? Especially when I see a lot of like males that are maybe more emaciated.
Yeah.
They seem to have lost a lot of volume laterally.
Yes. So you need to give them a little bit of lateral too.
Okay.
So if a patient is really thin, like your runners or really just thin, right? So you create a little bit of lateral volume for them, right? So you do the medial, you do a little bit of lateral. And at that point, they may look a little bit too sharp, right? Because they're so thin.
Yeah.
So that's the time when they need their sculpture. So you do sculpture temples, sculpture on the lower face, and you kind of like blend the little volume that you gave them. Let them rest, come back, do cheeks again, right? And if they start looking again sharp, you do more sculpture. So you're kind of like doing cheeks, but then kind of like fading, volumizing the whole face.
Gotcha.
Yeah. Because if you try to do just cheeks with patients that are so thin, then they're gonna look like Maleficent.
Yeah.
So you can't do that. So you have to kind of like go slowly, right? Create a little sharpness first and then blend it with the sculpture. Sharpness, blend it with the sculpture. Yeah. So it takes both sessions.
With most men that come to approach you, like, do they have a desire for filler? Do they even understand it? Or is it something you have to educate them about?
It depends. Sometimes they come in just for the Botox consult.
Uh-huh.
And like I said, I do the full consult. And I even tell them, right, I'm just gonna recommend you what I would love to do on you. It doesn't mean that you have to do it, right? I'm just going to recommend everything. And then you decide if you want to do it. And then you're kind of like planting that little seed. I feel like they already heard of it. You already told them, right, really politely that they need filler here and here because of this and that. You did their Botox, they look great, right? Because they love their Botox. And then they're kind of like, maybe I should try what she told me in the beginning. So I think that taking time with your first consult is really important.
Awesome.
That's where you develop that little trust with the patient.
And you'd mentioned earlier about how having the broad chin is really important for men. Is there anything that with regards to, like, I've seen a lot of men that have a small chin, like you might, like we see it all the time in anesthesia, like when people go to sleep, or they have like like a very low Mallampati class, right?
Yeah.
Like, so how do you build that up for people that have a small chin?
When we're doing jaw lines and chins, we have to treat cheeks first. And
Gotcha.
males are not an exception, right? So we have to build up the mid face first, and then we go with the chin. For females, the angle or the area where you want to inject, it has to be kind of like in the medial aspect of the chin, right? So it's going to be aligned with the lateral canthus, medium canthus, la ala of the nose, and then you go down all the way straight, and it's kind of gonna be aligned with your nose. Okay, and so it's going to be kind of like right here in the middle for females. For males, it's going to be more aligned to the oral commissures. So as you see, we have a lot of room, right, to play with the males. And that's why I was telling you, sometimes we kind of like, if the patient wants to, right, we try to recreate that little cleft chin that it's kind of like so manly. And you can do 2 separate injections, right, to recreate that. And obviously you're going to make the chin broader, which is okay for males. So males, remember, strong chins, strong jaw lines, but you still need to give support to the cheeks first. If not, it's going to look, it's not going to look good.
One other question I had was regarding males with the like the hollow temples. Like you often see this, like you mentioned before, like with runners or people that like are endurance people.
So males and females, okay, if they have temple hollowness and you start building up the cheeks, this is going to look worse. So sometimes if the patients are super hollow in the temples, I start with temples before even touching the cheeks. If they're coming to me and they look already sunken over here, if I do cheeks, this is going to look worse.
Right.
So sometimes I do start with the temples. With temples, you know, we can do it with filler, right? My favorite product is Sculptra for temples. I feel like it works natural, subtle, gradual over time. It's awesome. So I normally do Sculptra. You could do Voluma, you could do Lift, any of your more robust products, because remember, temple is kind of like a deep area and you're placing that product kind of like deep as well. So you really need some kind of like substance to give volume there. And remember, it's just one single area. So I do the 1 injection technique, 1 centimeter over, 1 under, and then inject there, obviously aspirate, right? And nice and slow, and then just massage it because it's one single area. So it's not going to go anywhere. It's kind of like trapped in between those section of a temple.
So imagine you did a injection of HA on a patient. They call and say, well, I'm not really in pain, but now I'm in discomfort. Like, how would you maybe like triage them to make sure they don't have like an occlusion? Because
I will send a picture first of all, right? Sometimes I will kind of like FaceTime them. And because I want them to do kind of like the capillary reflex kind of like test, and I need to see it.
Yeah.
And if there's any, when in doubt, take it out.
Okay.
Just bring him back, dissolve everything, and then bring him back and do it later on. Do it again. So when in doubt, take it out. Don't wait. Don't wait to see if it is or not. And it's hard to assess, right? Because pain is subjective, right?
Yeah.
So, but that's why I always tell my patients whenever they're leaving, you're gonna be tender. Tenderness is fine, right? So they're not expecting not feeling anything, right? They will be tender. But if it's pain that maybe you took Tylenol and it's still there, if it's a sharp, steady pain, that's not normal. But tenderness is very normal.
Another question is, if you were to dissolve, how would you dilute it, especially if you don't think it's a VO?
So I don't dilute the Hylenex. I just inject straight. Whenever it's not a vascular occlusion, it's kind of like hard to assess. So I will just go in the areas that I remember treating, right? You can always use your ultrasound, right? And see where the product is and dissolve it with the guided ultrasound. Whenever it's a vascular occlusion, you just flood the area and you go from where you see the kind of like the blanching starting and all the way kind of like flood the area until you see the blood flow coming back. You flood the area, you can give him a warm compress, you massage, you wait a little bit, an hour later, if it's still there, flood the area again. Don't let the patient go until the blood flow is back. Always have like a doctor or a mentor or somebody more experienced than you that can guide you into these type of things. I have an emergency kit in my office where I have everything that I need in a like kind of like a box, which is really handy, and I have everything there. I have phone numbers. Your reps can be a good point of contact if anything like that happens, because they know their MSLs, right, for their companies that can kind of like help you and reach out. But always have somebody don't isolate yourself. Always like be able to reach your neighbor across the street if you need more Hylenex and anything. Just don't isolate yourself. Kind of like create a little community where you can kind of like call and ask and send pictures. And we all do it until like even like 15 years later, I still have like things that I'm like, what is this? And I text my friends that are doing it for like the same time, or the MSL for the company. They're always great point of contact for any questions like that.
The other question that came through was when you say flood the area, would you use a cannula or would you use a needle?
You can use a cannula or you can use a needle, depending on what you were injecting, right? If you were doing cheeks with a cannula, go with a cannula and flood the area. If you're doing it with a needle, you know that the product is deeper, go with a needle. Remember that the vessels are permeable, so you don't have to inject in the vessel or where you created the vascular occlusion. The Hylenex is still gonna permeate, and it's gonna get absorbed through the vessels. So as long as you flood the area, you should get that Hylenex where you need it.
Thanks, guys.